This is the clinical application of assessment and treatment for a client with dementia. So first, we will start off with the client profile, some demographic information. Today we are going to be talking about Miss Cherie Thompson. She is an 82-year-old female diagnosed with frontotemporal dementia who resides in Texarkana, Arkansas. She currently lives at home with her husband Joe Thompson, 81, and often receives support from her daughter Allie Thompson, 23, who resides just 5 minutes from her residence. She was born on May 5, 1943. Ms. Thompson was formerly an elementary school teacher. She taught second grade and officially retired from the field in 2010. Ms. Thompson began experiencing symptoms of frontotemporal dementia in September of 2021. Since her diagnosis, major declines were noted in her language abilities, executive function, and behavior. In conjunction with the diagnosis of dementia, Ms. Thompson also suffers from gastroesophageal reflux disease, also known as GERD, and hypertension. She currently takes 3 medications daily: 25 milligrams of an ACE inhibitor, 20 milligrams of omeprazole, and 50 milligrams of Zoloft. Ms. Thompson is a retired elementary school teacher. Her family states that she enjoys crafts and reading. She is formally known to be socially active and highly organized with strong communication skills and an expansive vocabulary. Before her diagnosis, Ms. Thompson enjoyed attending church and a weekly book club. Since the progression of her disorder, Ms. Thompson is unable to attend book club but continues to attend church virtually. Ms. Thompson resides at home with her husband Joe Thompson as her primary caregiver. Her daughter visits daily to support her husband with caregiver responsibilities. She has no history of smoking or drinking. Ms. Thompson's disorder is caused by progressive atrophy of various cerebral structures, including her frontal and temporal lobes. Her family history indicates a record of previous cases of frontotemporal dementia with her grandmother, Marie Thompson. Ms. Thompson's family history contributes to the notion that her disorder is caused by an inherited genetic mutation. Before Ms. Thompson's diagnosis, she demonstrated strong expressive and receptive language skills, a high level of independence, and solid executive function skills. She often participated in a variety of activities, including attending church weekly, attending a weekly book club, and various volunteer opportunities. Ms. Thompson was referred by her primary care physician due to symptoms of primary progressive aphasia, a form of frontotemporal dementia. She displays reduced expressive and receptive language skills and increased communication difficulty. Her husband and daughter report that she often has word-finding difficulties, reduced verbal output, and mild difficulty understanding spoken language. Ms. Thompson completed an MRI in March of 2022. The findings of the MRI indicated bilateral atrophy of her frontal lobes as well as atrophy of the anterior portion of her left temporal lobe, which is consistent with her diagnosis of frontotemporal dementia. She completed a PET scan in January 2023, which indicated a reduced metabolic rate bilaterally in her frontal lobes. Ms. Thompson displays significant impairments in language, attention, memory, and executive function. Selective, divided, and sustained attention are severely impaired, as well as her short-term and working memory. Her family states that they have recently noticed increased impairments in her executive function skills, such as planning, attention, organization, memory, and inhibition. She has difficulty adjusting to new plans and organizing her thoughts for verbal communication. Ms. Thompson also displays increased difficulty suppressing inappropriate thoughts and behaviors and often interrupts others when speaking. Ms. Thompson's family and physician indicate emerging difficulties with her expressive and receptive language skills. She displays symptoms of anomia, including word-finding difficulty, hesitant speech and frequent pauses, and instances of circumlocution to aid communication efforts. Along with expressive language deficits, Ms. Thompson also displays reduced comprehension of spoken language. Additionally noted are impairments in written language and reading comprehension. Ms. Thompson experiences frequent spelling and grammar errors, as well as reduced ability to understand written material. Ms. Thompson has experienced many functional impacts since her diagnosis of frontotemporal dementia due to her increased difficulties in executive function and communication. She finds it difficult to follow conversation, stay on topic, and organize her thoughts for functional communication. Her family explains that she often struggles to focus on a task and has difficulty multitasking. Reduced inhibition has caused Ms. Thompson to frequently interrupt others during conversation and at times display socially inappropriate behaviors. Memory deficits make it difficult for Ms. Thompson to keep track of conversations and complete multi-step directions. Ms. Thompson's deficits make it increasingly difficult for her to express her needs, understand others, maintain personal relationships, and participate in daily activities. Now we will discuss Ms. Thompson's assessment plan. Ms. Thompson completed the Mini Mental State Exam, a modified version of the Montreal Cognitive Assessment, and the Repeat and Point Test. The Mini Mental State Exam tested Ms. Thompson's orientation, memory, attention, language, and recall abilities. The modified Montreal Cognitive Assessment assessed multiple domains, including memory, executive function, orientation, language, attention, and visuospatial skills. The Repeat and Point Test assessed Ms. Thompson's comprehension and repetition abilities. The results of the assessments were as follows. On the Montreal Cognitive Assessment, the modified version, she received a score of 7 out of a possible 30 points. On the Mini Mental State Exam, she received 15 out of 30 points. On the Repeat and Point Test, it tested repetition and comprehension. She received an 8 out of 20 possible points for repetition and a 16 out of 20 possible points for comprehension. Ms. Thompson's score of 7 out of a possible 30 points on the Montreal Cognitive Assessment indicates severe impairments in selective and divided attention, short-term memory, executive function, and orientation. Moderate to severe anomia was noted as well as reduced comprehension of spoken language. Her score of 15 out of possible 30 points on the Mini Mental State Examination concludes findings consistent with a significant language impairment. The exam also indicates moderate to severe deficits in orientation, memory, recall, and attention. The results of the last assessment completed by Ms. Thompson, the Repeat and Point Test, display errors consistent with symptoms of logopenic variant primary progressive aphasia. The Repeat and Point Test indicates a moderate to severe impairment in repetition and mild impairments in comprehension of complex language. These findings are consistent with logopenic type primary progressive aphasia, a progressive neurodegenerative disease. It is assumed that Ms. Thompson's repetition and comprehension skills will continue to decline due to the progressive nature of her diagnosis. Now we will discuss some informal assessment measures of the evaluation. Some of the informal assessment measures were patient and caregiver interviews, conversational observation, writing samples, functional communication tasks, and picture description tasks. Observation of Ms. Thompson's natural conversation abilities indicates hesitant, choppy speech. She frequently used circumlocution during conversation to supplement word-finding difficulties and demonstrated poor topic maintenance intermittently. Semantic paraphasias were frequently present in conversational exchanges. Functional communication tasks were used to determine Ms. Thompson's ability to participate in frequently occurring communicative situations. These tasks included opportunities for Ms. Thompson to request assistance, order food, and describe medical symptoms. Assessment of these informal tasks indicates moderate to severe difficulties in functional communication due to her symptoms of logopenic variant primary progressive aphasia and associated cognitive deficits of frontotemporal dementia, including word-finding difficulty, poor topic maintenance, etc. Picture description task revealed severe word-finding difficulty, disorganized discourse, and poor topic maintenance. The last informal measure completed by Ms. Thompson was a writing sample. In the writing sample, phonological spelling errors and letter substitutions were noted, as well as frequent hesitations, likely due to her word-finding difficulty, and reduced complex grammatical structures. Now we will move on to discuss Ms. Thompson's diagnosis. Cherie Thompson presents with logopenic variant primary progressive aphasia. She displays moderate to severe impairments in expressive language skills and mild impairments in auditory comprehension. Assessment of her expressive language abilities revealed frequent word-finding difficulties, phonological errors, and significantly impaired repetition consistent with features of the logopenic variant of primary progressive aphasia. Additionally contributing to the diagnosis are her written language skills, which display many phonological errors and reduced grammatical complexity. Ms. Thompson's receptive language skills indicate difficulty understanding complex language and commands. Her comprehension of simple language remains intact. Pragmatics also appear largely unaffected. However, the efficiency of Ms. Thompson's communication is significantly impaired. The inefficiency of her communication and deficits in multiple domains have various functional effects, including difficulty participating in fast-paced, complex conversations, inability to maintain a typical conversational pace, and her ability to effectively communicate in frequently occurring communicative situations. Ms. Thompson's receptive language deficits reduce her ability to understand vital information regarding her health, finances, and other important personal information. Ms. Thompson's diagnosis of primary progressive aphasia is progressive in nature and is believed to cause an ongoing decline in cognitive abilities, language skills, and functional communication of daily living. Next, we will discuss Ms. Thompson's treatment plan. Her long-term goal reads, Cherie Thompson will use communicative support strategies to maintain functional communication skills significant for daily living. Her short-term goals are, given moderate cues, Cherie Thompson will follow single-step directions given verbally with 80% accuracy across 3 consecutive sessions. Given writing templates and verbal prompts, Cherie Thompson would complete functional written tasks using simplified grammar in 4 out of 5 opportunities across 3 consecutive sessions. Given minimal cues, Cherie Thompson will use 2 compensatory strategies during conversation in 4 out of 5 opportunities to reduce word-finding difficulties across 3 consecutive sessions. Additional short-term goals are, given minimal cues, Cherie Thompson will repeat personal information such as her name, address, diagnosis, age, and phone number with 80% accuracy across 3 consecutive sessions. Given mild background noise, Cherie Thompson will attend to a selected task for at least 3 minutes in 4 out of 5 opportunities. Given minimal cues, Cherie Thompson will produce appropriate responses to functional questions in 4 out of 5 opportunities across 3 consecutive sessions. Now we will discuss intervention strategies for Ms. Thompson using the life participation approach to aphasia. These interventions include errorless learning, supported conversation for adults with aphasia, communication partner training, and promoting aphasia communication effectiveness. Errorless learning intervention will be implemented to support memory, recall, and comprehension skills. Supported conversation for adults with aphasia will help improve auditory comprehension, word-finding difficulties, attention, and functional communication. PACE intervention will teach Ms. Thompson needed strategies for oral expression and multimodal communication. Finally, communication partner training will help teach her frequent communication partners strategies to reduce the number of breakdowns in conversational exchanges. Next, we will discuss multidisciplinary and caregiver considerations. Other professionals, as well as caregivers of Ms. Thompson, should be aware of her deficits in language, comprehension, and executive function so that they can adequately support her. Caregivers should use communication strategies learned throughout therapy, as well as environmental modifications to support communication efforts and safety. Other professionals should provide support for daily activities and consider various limitations due to the progressive nature of her disorder. Considerations of other professionals should focus on Ms. Thompson's safety, activities of daily living, and psychological or behavioral changes. The final summary of evaluation concludes that Cherie Thompson presents with logopenic variant primary progressive aphasia, a form of frontotemporal dementia. This diagnosis primarily affects various executive functions, expressive and receptive language skills, and her attention and memory. Ms. Thompson displays specific language impairments, including severe anomia, semantic paraphasias, poor repetition, reduced grammatical complexity, and reduced auditory comprehension. Impairments in selective, divided, and sustained attention affect her ability to understand complex information, participate in conversations with distractions, and maintain focus on complex tasks. Cherie's ability to produce written language is characterized by reduced grammatical complexity, phonological errors, letter substitutions, and semantic paraphasias. Her ability to recognize her deficits is also slightly impaired, as well as many domains of executive function. Although Ms. Thompson presents with various impairments in multiple domains, she maintains a positive attitude toward medical and therapeutic intervention. Ms. Thompson remains motivated to progress towards her goals and displays a strong desire to communicate effectively. She responds well to structured therapy tasks and receives daily support from her spouse and adult daughter. Ms. Thompson maintains most visual and motor abilities, which will aid in her ability to participate in therapy tasks. Ms. Thompson's short-term objectives were chosen to provide her with repetitive, functional, and highly structured practice for various areas of communication and executive function in order to maintain functional communication and cognitive abilities for as long as possible. The chosen objectives will help maintain her ability to verbally communicate via written material, participate in daily activities and conversation, and maintain her independence for an extended period of time. Ms. Thompson displays the ability to learn new information if the material is highly structured, repetitive, supported by visual cues, practiced functionally, and able to be easily implemented by caregivers into daily activities. Therapy activities should be structured to reduce Ms. Thompson's cognitive load, as activities requiring a high level of cognitive demand have been known to cause frustration and discouragement. Cherie Thompson's prognosis is guarded due to anticipated cognitive decline over time. However, her prognosis for short-term objectives to maintain some communication and cognitive abilities is fair. This prognosis can be attributed to continued support from family and caregivers, her ability to understand and utilize various supports, and her conserved long-term memory.